Hi, I'm again Dr. Rochelle Wolf. I'm a co-director of research for the White Dress Project. I'm going to be here with Tennille today, walking you through, our What the F series on how do fibroids affect my fertility. So I'll let Tennille introduce herself and our many special guests we have tonight.
Good evening, everyone. My name is Tennille Bruce, and I am a committee member with the White Dress Project Research Committee and also a maternal health specialist. And that specialist is basically an umbrella for a bunch of things. And on our panel this evening, we have amazing folks gathered to share their knowledge, their expertise, their experiences with us during our talk. We have Dr. Wendy Kohung joining us. We also have Dr. Alexis Gadsden, and we have fellow fibroid fighter, Nicole Jones.
Hi.
So Tanya, do you want to switch to the slides?
Yes, sorry, technical difficulties. Please stand by.
If I was in control, it would be a lot worse. So
it would not be a Zoom without some sort of technical difficulty. So
This is true.
Now we've officially started. All right, here we go.
So again, we'll get just down to just general kind of outline of how the night will go. We're going to kind of do a little bit more formal introduction of our panelists. Then we're going to introduce our topics on do fibroids affect fertility, kind of go through just some general information, background, and then Dr. Kohung is going to give some more specialized information. We'll hear about Nicole's incredible story, and then we'll finish off with some topic discussion and questions from the audience or share your story. So again, you met me and Tennille, so we'll skip us.
So this is the slide where we get to pretty much absorb the awesomeness of our professional guests joining us. So again, Dr. Alexis Gadsden, who is a third-year fellow in reproductive endocrinology and infertility with Women and Infants Hospital of Brown University. And then we also have Dr. Wendy Kohung, and she serves in the division, well, she's a division director of reproductive endocrinology and infertility with Brigham and Women's Hospital.
Yeah, actually, I just want to make a small correction. I'm actually with Boston University and Boston Medical Center. I did train at Brigham and Women's Hospital, so that may have been where you saw that. It's part of my bio.
Thank you.
And I also want to mention that Dr. Kohung is an integral part of a program that the White Dress Project is doing in conjunction with Boston Medical called Centering Patients with Fibroids. So we're super excited about that. If you are a patient at Boston Medical, please, and you have fibroids, please inquire about that. All right.
And also, again, we have fellow fibroid fighter Nicole Jones joining us during our talk this evening. And Nicole, if you don't mind unmuting yourself and just giving us a little bit of background about yourself, and then later on this evening, you'll share your story with us.
Well, my name is Nicole Jones. Thank you all for having me. Always such an honor to be with I call you all my sisters. Backstory, I'm actually known for having a 27 centimeter fibroid, one of the largest with my pregnancy, carrying my baby almost just about full term. We went about 37 weeks, and she's as happy as you'll see her, as happy as she wants to be. And it was a really interesting, journey for me because I didn't hear anybody being pregnant with such large fibroids. So to kind of go through this myself and feeling alone, I am making it my mission to make sure that there's so many others that may be going through what have gone through, of actually saying, hey, we got this. And living proof. I have a beautiful, now she just turned 2, little girl, but it was definitely a journey of advocating myself, and I'll get more into that when it's my actual time of how I advocated for myself to make sure that I had a long life and my daughter got here.
Thank you so much, Nicole.
Yeah.
Okay, so through our discussion tonight, we're going to just do a little bit of introduction about what are the challenges associated with fertility research, what are the challenges on researching the effects of fibroids on fertility, and then how does stress, diet, physical activity kind of influence infertility. Next slide. So if you've seen any of our previous What the Fs, we always have Tanya likes to come up with little acronyms. So we have our TOTM, which is term of the month. And this month, again, in regards to National Infertility Week, we took the term infertility. So what is infertility? According to the CDC, infertility is defined as not being able to get pregnant, conceive, after 1 year or longer of unprotected sex. Because fertility in women is known to steadily decline with age, some providers will treat women aged 35 years and older after 6 months of unprotected sex and inability to conceive. Some other kind of related terms, kind of what is recurrent pregnancy loss? It's defined as having 2 or more spontaneous miscarriages. And a miscarriage is a pregnancy loss that typically happens 20 weeks or less in gestation. An interesting fact around that is more than 80% of early pregnancy loss does occur in the first trimester, and the risk of miscarriage declines after about 12 weeks of gestation. Let's go to the next slide. So what are some of the challenges associated with fertility research? Well, the cause of fertility or infertility, is not always clear. So there's kind of this 1/3, 1/3, 1/3 rule, where it can be the female partner, the male partner, or in about a third of the time, it can be a cause from both partners. We also know that about 25% of the time infertile couples have 1 or more factors contributing to their infertility. And, even confounding this more is, infertility can be related to medical, lifestyle, and environmental factors all looking to it. So really this illustrates the importance of an evaluation by a reproductive endocrinologist and infertility specialist if you're struggling with infertility or pregnancy loss. So next. So now kind of going on, this is a little bit more complex, is what are the challenges on researching the effects of fibroids on fertility? And kind of like the 2 topics, I kind of think of chicken versus an egg. So infertile women are generally nulliparous, meaning they've never given birth. And we know from research that parity actually has a protective effect on developing of fibroids. Also, we know that infertile women may be exposed to a higher risk of fibroids just because they've never had children, right? Because of that protective effect. And then when we look at the prevalence of fibroids, they increase with a woman's age, where fertility actually declines with the woman's age. And so the relationship of that third point is particularly troublesome because of the trend of women now delaying motherhood, often into their late 30s, if not 40s, at an age, again, where fibroids are becoming more common, fertility is declining. And then from last month on our Association of Fibroids and Endometriosis, we do know that fibroids are associated with other conditions that can cause cause infertility, like endometriosis. And then to make this even more complicated is that studies are complicated by the fact that fibroids present differently in each woman in number, size, and location. And so if you look at that the relative effect of each fibroid on fertility may differ based on its location, size, particularly location. And then within each individual woman, the combination of different fibroids may ultimately have a very unique effect on infertility for that individual. So again, really, really complicated. And so that's why, the data out there can be a little bit difficult. And then when we look at fibroids too, one of the main challenges in studying the association between infertility and fibroids is really asking the question too, were the fibroids even present at the time the woman was planning on trying to get pregnant or conceive? And did the fibroids change over time? So really, really complex question. Next slide. So what are some of the proposed mechanisms of fibroids on fertility? And this slide kind of just generally describes it. But basically, fibroids can interfere with basically the myometrial, the muscle contraction of the uterus, and therefore interfere with how sperm progresses through the reproductive tract and with embryo implantation. Fibroids can also distort the anatomy or even obstruct the fallopian tubes or affect their function. So again, the egg can't get to where it needs to go. And then research has also shown that submucosal and possibly intramural fibroids can create this adverse endometrial inflammatory response that again can affect how sperm migrate and get to where they need to go, and also have effects on the implantation of the embryo. And some studies have shown that even the presence of fibroids can kind of alter the normal endocrine or hormonal environment as well. So next. So what do we know at a very kind of cursory level on how fibroids, what we know about fibroids and pregnancy? And basically, very common statistics around fibroids is that they're present in about 5 to 10% of infertile patients, and maybe the sole cause in about 1 to 3% of patients. Based on studies on IVF studies, basically there's research that supports the adverse effect, particularly of those fibroids that kind of sit in the lining of the uterus, like what's labeled as 0-1, and kind of distort the uterus as number 2, on having adverse effects on pregnancy. The interesting thing though is, because fibroids have such a high prevalence in the general population, the true impact on fertility remains in question. And the effects really on natural fertility outside of the IVF world is a little bit unclear. And why is that? Because when we look at research from women who have infertility and undergoing IVF trials, that some of those mechanisms that we talked about on pregnancy, the sperm and how fibroids can affect that, those things may get bypassed a little bit. So that's why sometimes looking at just the IVF data may be a little bit difficult to translate to just natural fertility. So in looking at this subject, in 2021, Samagliana, a researcher who has produced a lot of papers out of Italy, I believe, he tried to answer this question on the effects of fibroids on natural fertility by basically reviewing the literature that's out there through a systematic review and meta-analysis. And unfortunately, when he looked through there, he found about 11 studies, narrowed it down to about 4. And, essentially, he basically concluded that the association between fibroids and infertility have been insufficiently investigated, that epidemiological studies suggest fibroids may interfere with natural fertility, but more studies and research is really needed. So I'm excited to have our 2 experts here who can kind of answer some of these more basic questions that is really, really needed. And this also really highlights, and I'm going to put a plug in for this, the importance of research supporting legislation like the Stephanie Tubbs Jones Uterine Fibroid Research and Education Act, The NIH is also really trying to push to get women into research studies, because we really need to better design studies to answer these questions and ultimately improve women's health outcomes. So that's kind of just a general introduction from that standpoint. Neil, do you want to talk about some other effects?
So I am going to talk about the impact that stress, diet, and physical activity can have on fertility. So when we talk about stress, and a lot of terms and a lot of words come to mind with regard to just relax, just chill out, and it's easier said than done. So I'm here to basically give us a rundown on stress and some of the ins and outs and the differences of stress, because stress is not a one size fits all type of thing. So stress and infertility are like cousins. They play very well together in a very cyclical way. So stress interferes with a woman's ability to get pregnant, and women dealing with infertility often report elevated levels of mood disorders like anxiety and depression. So you can see how this kind of moves in a circle. And with regard to stress, there are two main types. There's acute stress, which is short term, and then we have chronic stress, which is long term and tends to linger. Some examples or causes of acute stress that include traffic jams, crowds, loud noises, running late to an appointment or a meeting, arguments with loved ones, deadlines for work projects, losing essential items such as your wallet, your keys, or your phone. And some symptoms to look out for when we're experiencing some of these daily pet peeves are anxiety, irritability, mood swings, anger, trouble with sleeping, especially that argument after a loved one, and a general lack of focus. As far as examples and causes of chronic stress, which is a little bit more hard hitting, we're looking at relationships, looking at trauma or post-traumatic stress disorder. We're also looking at our environment, and not just the external environment, although that plays a big role, but also our internal environment. So we're talking about emotions, and we're talking about our mental state. And also work. Work tends to check all of the stress boxes. So work is definitely something that can contribute to chronic stress. And some symptoms to look out for with this more long-term form of stress: fatigue, headaches, decreased energy, body aches and pains, insomnia, which is different from trouble with sleeping. Also frequent illness or trouble with recovering from mild illness. So, you kind of that cold that refuses to go away despite your best efforts. High blood pressure, and also digestive issues such as irritable bowel syndrome. And the way that stress can impact, just our day to day, with all of these causes and symptoms to consider, we're looking at weight gain or weight loss. We're also looking at a decrease in one's libido. And so you're starting to see how this is just creating a perfect storm for directly impacting one's fertility. Also, that there are stress hormones. So stress hormones are referred to as cortisol and adrenaline, and together they control our fight or flight response. So in stressful situations, our bodies become inundated with these stress hormones in preparation to either fight off danger or flee the scene. So during fight or flight, you'll notice that your heart rate increases, your blood pressure starts to rise, your muscles tighten, and your senses sharpen. Okay, so keeping all of that in mind, stress responses, they are essential for our survival. They keep us mindful of what's going on and direct our actions. But you can see how being in a constant state of just I'm on and I'm prepared, you can see how that can negatively impact your health. I mean, your heart is thumping all the time, a rise in your blood pressure, muscles not relaxed, your senses are on go constantly. So you can see how this can, how this can have a negative impact and cause poor outcomes with our fertility and also with our health in general. Next slide, please. So with regard to how do we beat stress, okay, because it can definitely seem like this insurmountable mountain. And so we're looking at treating both acute and chronic stress. And no matter if your stress is short-term, like a traffic jam, or long-term dissatisfaction with work, the changes are going to involve lifestyle. So I'm going to specifically talk about diet and exercise, even though lifestyle changes definitely branch out into mindfulness and other, modalities that we can, that we can increase in our lives. But again, just focusing on diet and physical activity, for the majority of us, life is very sedentary. So because of that, we have to consciously prioritize daily movement and physical activity. The same way that we schedule meetings, we have to schedule time to get up and move around. We have to schedule time to exercise and to engage our bodies and get our blood pumping. And this doesn't have to be you in the gym for an hour or even, over that, just overly extending yourself. Physical activity can be 30 minutes a day. That's enough to get the blood pumping, to get your heart rate up, and also to release endorphins, which are our happy hormones. And it also helps with managing the symptoms of stress when they do appear. Because when we're in an elevated mood due to the endorphins, we tend to have a sunnier outlook, and we're able to look at stresses and we're able to look at problems a little bit more objectively. As far as some examples of things that we can do every day just to get ourselves moving, this can involve just taking a simple walk, yoga, strength training, swimming, dancing, biking, skating, low impact workouts. And I name a bunch of different kinds of workouts because the point is to do an activity that you enjoy and also to have some variety. So picking maybe one or two activities that maybe bring you back to your childhood and just incorporating that within your week. And so moving on to what we're putting in our mouths, we're all familiar with the saying, you are what you eat. So stress has a really, really sneaky way of adding chaos to our eating habits. And this is going to look like overeating or too much junk and not getting enough of what's vital. So that throws our health off balance. And in order to curtail that, we want to keep our blood sugar levels low. And that basically is going to involve eating the rainbow, healthy fats and proteins, complex carbs and grains. A lot of this information is not new information, but it's helpful to have reminders, because when dealing with infertility and more specifically uterine fibroids, it definitely can take a toll on our priorities and what we're focusing our thoughts on a daily basis.
So now let's have Dr. Kwo Hung kind of give us latest and greatest updates, and have Dr. Gadsden give any information she also wants to on the subject.
Hung, you're still muted.
Sorry. I didn't realize I was muted. Sorry. So yeah, so there was a question in the chat about severe mental disorders and fibroids and infertility. So I think that there's definitely a lot of data showing that that in patients with infertility have more mood disorders, and then also fibroids, interestingly, also are associated with mood disorders. We just recently published a paper looking at an insurance claims database, about 300,000 women, looking at the association between fibroids, anxiety, depression, and self-directed harm, or basically, suicidality. And there was, for patients with fibroids who had pain-related symptoms versus more heavy bleeding, those with pain-related symptoms had a higher risk of having depression, and also those who had a hysterectomy for fibroids also had a higher risk of having depression. Possibly, it was thought that the pain was probably predisposing the patients to having more depression, and then also hysterectomy, whether or not the ovaries were taken out, might also contribute to the incidence of mood disorders. So it's a really interesting field that more research is coming out of. So just to answer that question. So I just have a handful of slides, like about 8, but I'm going to be reiterating some of what the prior speakers have already said. Basically, that, let me just make sure I can advance here. Let's see. Oh yeah, so Rochelle had gone over the definition of infertility, and I'll just reiterate it just very briefly, that we consider patients who are under 35 that have been trying for 12 months and not using birth control. If they haven't gotten pregnant, then they have infertility. From 35 to 40, if they've been trying for 6 months without birth control, then we would consider that infertility to be evaluated. Or if they're 40 or over, or if there's some obvious cause, like they only have like 1 period a year, then those patients would be considered to have infertility and should be worked up immediately. Like was shown in prior slides, the incidence of uterine factor alone is actually not that high, just like maybe just fibroids alone, like maybe like between 1% to 2%. However, one thing to also consider is that many patients have multiple factors, either multiple factors female only, which is here in the yellow, or multiple factors female plus male. So there's usually more than one thing going on if a patient has infertility. So that's just one thing to consider here. The other thing to consider also is that this data was from the SART for the Society for Assisted Reproductive Technology, which takes all the data from reported in from all the IVF centers. And it's no secret that the utilization of IVF clinics is much higher by white Caucasian patients. So I would say that in this pie graph, most likely there's an underrepresentation of patients of color who might have a higher risk of having fibroids. So that may be also why this is so low. So can fibroids decrease fertility? Well, size and location determines the effect of the fibroids on fertility. So fibroids inside the cavity, as was shown by the prior speaker, are called submucosal fibroids. So those that are inside the cavity can contribute to infertility. Very large fibroids, such as greater than 5 centimeters in the wall of the uterus, such as here's like an 8 centimeter one that this MRI shows, pretty large. If they distort the cavity because they're so large, then they can contribute to infertility. And typically these fibroids should be removed prior to proceeding with infertility treatment, or if the patient has already done infertility treatment and they didn't get pregnant, the consideration should be given to taking them out. And I just want to point out, though, just because a patient has a few fibroids, if they're not larger on the inside of the cavity, most of the time they will not have trouble getting pregnant. So I want to point that out. So it's kind of like real estate, location, location, location. Submucosal fibroids, again, are the ones that are on the inside of the cavity. And those we feel are impactful to fertility. Here's some pictures of from a hysteroscopic view, fibroids on the inside of the cavity. Typically, they should be removed from patients who are having trouble getting pregnant. They can be removed hysteroscopically, which is no incision surgery, putting a camera inside through the cervix, inside the uterus. very large fibroids greater than 4 centimeters might require 2 of these day surgeries to get the whole fibroid out, because you can usually only remove small pieces at a time. And then intramural fibroids, or fibroids in the wall of the uterus, typically have to get large before they get to start affecting a woman's fertility. Infertile patients with intramural fibroids that are greater than 5 centimeters and distort the cavity could benefit from removal. Like Rochelle had pointed out, the research is difficult to do on fibroids because, number one, patients have many different numbers, sizes, and locations of fibroid, as well as patients are of all different ages, and they can also have other factors such as being older and their ovarian reserve is lower. So many different factors, and it's also very hard to randomize patients double-blinded because they usually know what they're getting, if they're getting surgery or no surgery. But there was a Cochrane review that cited a study, a comparative study, it couldn't be randomized, of 168 patients that were having IVF that had at least one large intramural fibroid of 5 centimeters or bigger. 84 of them had the fibroids removed in a procedure called myomectomy, and they did have improved live birth rates over those who didn't have surgery. So about 25% live birth rate versus 12%. So that was significantly different. And the fibroids can be, depending on how big and how many, they could be removed laparoscopically with or without robotic assistance. Maybe if there's only 2 or 3 fibroids that are not super large, they probably could be removed through the small keyhole incisions of laparoscopy, or they could be removed through a larger incision in the abdomen. This picture of the 17 fibroids here is from a patient of mine who did an abdominal myomectomy on. She actually just last week sent me a picture of her baby. She had done IVF with a prior center. They were trying to do it with the fibroids in place, and they couldn't reach one of her ovaries for an egg retrieval. So I did the surgery, we did the IVF, and then she got a very good result. She had a baby and also has some frozen embryos on the shelf for later. So that was a good outcome. And incidentally, she needed to have a C-section to have the baby, just because we had, it made so many scars, deep scars into her uterus, that we weren't really comfortable with the idea of having labor. So that's all that I have. Let's see here. Somebody had a question. Let me just see here.
It's a question.
Yeah, so somebody said, I was part of a research patient advisory for Mayo Clinic in Minnesota. There seemed to be a consensus the factor of genetics is extremely high. Yes, there's actually a study going on at the Mayo on the genetics of fibroids, in addition to the Brigham. I was also diagnosed with CPTSD and generalized anxiety this year. I believe this also had an impact on my overall health, or genetics being added to other research in other states areas. Yeah, so that's definitely an area of active research, looking at the genetics of fibroids. They also tend to run in families in some cases. So that is it's an active area of research. And then how many, so there's a question about how that patient, how many months post-op with your patient before she conceived? Good question. So I always tell my patients that after an extensive fibroid surgery like that, they have to wait at least 6 months. Sometimes some other providers make patients wait a year. Some providers will bend the rules a little bit. If someone's already 42 and they're kind of running out of time, they might make it shorter than 6 months. But yeah, we started doing IVF attempts after 6 months. So it was, I think she conceived on her, I think it was she did an IVF PGTA cycle and then did the frozen embryo transfer and then got pregnant after that. So it was fairly quick. Yeah.
The amount of time that we have anyone wait after surgery really depends on the situation. Our overarching goal in that waiting period is to give your body time to heal before we test it with a pregnancy. So you don't want, a baby growing inside of you while you still have an unhealed scar, because that can cause trouble in the future. So it honestly depends on the timing, like Dr. Puhan said, the age, and if you've already done IVF or if you still need to go through IVF. All of these things can kind of change our goals for that timing. So I think most often you'll hear anything between 6 months and 12 months is the normal period after having a
And then there was another question, how do you know your uterus is healed? Well, that's a good question. I guess you never really know for sure, but from prior literature looking at uterine rupture, it seems that so uterine rupture is where the uterus kind of breaks at the point of the weak point where at the scar. We know from C-section data that after 12 months, the risk of uterine rupture with a full-term pregnancy goes down. So yeah, but like Dr. Gadsden said, it really depends on like how many fibroids were taken out and how deep the incisions were. So it depends on a few other things as well.
There's another question here in the chat. I'll read it really quickly. I had 7 fibroids and some endometriosis removed in November and just went through my first IVF cycle in February. We had 2 embryos, but both were abnormal. My egg retrieval only yielded 3 eggs, but I had 8 to 10 follicles. Trigger shot. Is there a possibility that I did IVF too soon after the surgery and that might have affected the egg count? The left ovary had 8 follicles and the right only had 2, and most of the fibroids were on the right side, with a couple on the left along with endo. This is actually a pretty common set of questions that we get from patients after they have surgery. It's hard to tell without knowing the details of your surgery. Ideally, removing fibroids and endometriosis just affects those areas, but the uterus, ovaries, and tubes all share some supply. So it can be affected if you had a very big blood supply, I'm sorry. So if you had a very big surgery, it's possible that that could be affected, but we'll never have a true answer for this question. It could be that you do another cycle and have the exact opposite. You have more on the right and less on the left. It's really difficult to predict.
Yeah, and then one other thing, that's excellent. And one other thing I want to add is that if there was endometriosis, I don't know if there was endometriosis cysts, but sometimes if those were drained or stripped at the time of surgery, that could potentially affect the ovarian function later with later IVF cycles. So I mean, I guess the short answer is that, like Dr. Gadsden said, probably just the act of taking out fibroids is not necessarily going to affect the egg count being low, but maybe it was already like that, or something, if there was surgery done on the ovaries and for the endometriosis, that might have affected the response.
So I would love for Nicole to share her absolutely incredible story. So let's kind of let Nicole take over and tell this incredible story.
And if you hear a little Ava, she may have something to say. Oh my goodness. And she found bread. So this little miracle right here has been, it has definitely been a journey. Like so many women, it turns out that it was in our family, we're known for having a lot of, health issues pertaining to fibroids, which really wasn't spoke of when I was growing up. And I was under a lot of stress. I know young, but I was under a lot of stress. So I had a lot of complications when it came to my cycle, which I really just thought it was normal. So sorry. Which I just thought it was normal. Okay, lovies. And so that resulted in me having 6 miscarriages. We found out later on in my 20s that I had a miscarriage because I'm thinking I had a period, and I took a leave, which I didn't know was a blood thinner at the time, and was sent to the hospital, rushed. And the doctors were saying like, oh, what you took actually agitated your cyst, your fibroids. I was like, fibroids? They're like, yeah, are you under a lot of stress? I said, I am. They're like, yeah, that could have caused the rupture while you took, yes, honey, while you took the medicine. And so be careful, lovies. And so like I said, here I am. I was in my 30s during COVID, and unfortunately, within the first week of pregnancy, my stomach was growing at a rapid rate. And I have pictures. I had started this whole spiritual healing journey of making sure I try to stay as calm. I changed my eating habits. So a lot of what I had been used to, which was a lot of bloating due to the fibroids, had reduced. So honestly, I thought I cured myself. That was a bad idea. I should have went to the doctor. So when I found out I was pregnant, it was because my stomach was growing at a rapid rate. And so we found out that I was pregnant, and I was only 2 weeks, looking like I was actually in my second trimester easily. And by the time I got to my doctor at the 8 weeks checkup, he was like, "You're so petite, but you look like you are ready to give birth right now." I was like, "I know, that's why I'm here to see you." And so with, looking into it, we did an ultrasound, and his machine wasn't working. So he sent me on the other side of the hospital, and I'm just like, is there a baby heartbeat? What is going on? But why is my stomach so big? And at that moment, that's where we found one of my fibroids, which I had 4. But the biggest one was at 18 centimeters at 8 weeks. So something in me said the doctor is going to most likely ask for me to let this pregnancy go. So I sat into it. I went the next day, and that was the topic at hand. And he was like, "I feel like what's best right now, let's terminate the pregnancy, let's remove this fibroid, and let's treat it after, and then you can get pregnant." I can only speak for myself. I felt like I needed to keep going. I had peace of keeping going. And he gave me this look like, "Are you crazy?" He's like, and he gave me the pros and cons. He's like, I don't know. Most likely this is going to continue to grow. And I said, "Well, I believe, in a higher power, and I believe I can do this. So I rather just ask, you know what, let's just go." And thankfully I did, but that did come with a lot of pain and bed rest. I had to end up on bed rest for a good 6 months. That was very hard because I'm a busy person. So to sit to watch Netflix is not the most joyous thing for me. But I kept talking to myself positively and really visualizing that my baby was going to be in my arms. And we made it to 37 weeks, and she was born via C-section. By that time, unfortunately, the doctors wasn't sure if they were going to be able to keep my life and my child's life because of the size of the fibroid at that moment. So I heard the pros and the cons, still kind of just try to meditate into a positive state. And when I heard her cry, I knew we have made it. And the only thing that we could not do at that C-section was remove the fibroids. So that was a whole nother journey of healing with the C-section, try to breastfeed, be a new mother, and be in a good state. And I went through postpartum depression. And I just tried to maintain being strong. I thought we were going to go 6 months of waiting, but the doctor was like, "We're going to wait 3 months and then remove the fibroids." That was very scary for me because I was thinking that my uterus at that time probably wasn't healed, but he kind of reassured me, "I'm going to be okay. Let's do it." So 3 months, we ended up removing all the fibroids. All of it was all taken out, thankfully. Have pictures if anyone wants to see later on. Got you. I think it's the coolest thing personally that my body went through this and protected myself. And it was an unfortunate situation, but seeing how it's given so many women a little bit more hope to continue, it's been a blessing for me. The most unique thing about the removal of the fibroids, which they did try to request for me to have a hysterectomy. Mentally, for me, I wasn't prepared because I had went through so much in that 9-month period, and then having to heal, and then just mentally, I wasn't prepared for something else to be removed. So the doctor reassured me he was going to try, and he was successful. successful. So I only had an open myomectomy. So I have a nice little, I call it a storyline going up my stomach. And Ava looks at it. I say, it's a storyline, baby. This is where you came from. And so but the one thing that the doctor had said that always shakes me to this day is he said, you know what, in all of this whole journey, we never seen the grapefruit size fibroid in your uterus. Mind you, I've had countless tests and no one's seen this wonderful grapefruit size in my uterus. And the doctor was like, I don't know, one, how you got pregnant, and two, was able to carry this whole pregnancy. He's like, I've seen countless, women, and he's like, I don't know this. And he started welling up with tears. And I was just like, you know what? I don't know either, but obviously this child is supposed to be here. And I feel honored that I can say I'm her mom and I fought for myself. Now, is this the same story for everyone else? Can't say that. I definitely feel like you have to listen to your intuition of what works for you. And she's happy that she has her water and bread, but she's healthy. She is healthy. And yes, and she is just one big blessing. And yes, and she's gonna say hello. So hopefully it's a little bit of encouragement that, my story of really advocating for my own health. And that was like the biggest thing, is making sure I was able to advocate for myself. And when I tell people I had a beautiful pregnancy, they give me the side eye, like, how is that? And I was like, because I was intentional with every decision, of being in a peaceful state. And I'm happy that I did it my way, and not everything was peachy, but I still have peace. She's here, and I'm here to tell this story. Yeah, you say bye-bye.
Bye-bye.
Bye-bye. So I'm sending you guys so much love and light. If there's any questions, yes, sweetheart. If there's any questions, please let me know, and hopefully I can, continue to share my knowledge with everyone.
And I think the story just kind of goes to show that, like Tanya, the other co-director of research, always hears us talk about the uniqueness of fibroids. I'm originally from the Midwest in Minnesota. So I always say, fibroids are like snowflakes. So, each one has its own unique individual footprint. And then you take that into the fertility part of things. It really is having this collaborative approach and really listening to your body and having really supportive providers who are going to help guide, listen to you, and help you make the best informed decision. So thank you so much, Nicole. It's an incredible story.
Thank you for having me. Such an honor.
Thank you, Nicole.
Thank you, love.
I just wanted to mention one thing that I think kind of addresses one of the questions in the chat. I don't think we've talked about it much during this particular webinar, but the fibroids are pretty common. Almost everyone has fibroids, and fibroids are essentially fed by the hormones that control your cycles. So as long as you're having normal cycles, fibroids will continue to grow. And I know that there is a question in the chat about whether or not we should try to have fibroids removed, and you've had fibroids removed at some point and they're slowly growing. We typically counsel patients that if you are going to have fibroids removed, the time to try to get pregnant, if they were otherwise asymptomatic and you're removing them for the purposes of fertility, is to try to get pregnant as soon as you're cleared by your doctor, because we know that with time, the fibroids will return. And that timeline is not clear and can be different from person to person. So if you are discussing this with your doctor, it's worth it to consider your timeline for attempting to conceive and figuring out the best timing for your surgery with your doctor. If you had heavy bleeding or pain with your fibroids, it's a little bit of a different discussion, but we are kind of working on a time clock after you had your fibroids removed for the purpose.
And Dr. Kwo-Hong and Dr. Gatton, we have you here. So I'm an interventional radiologist. And so, this question comes up a lot. There is a lot of debate and studies. I know early in my career, when women wanted to attempt to get pregnant, our answer was UFI is not an option for you. Slowly over time, with very poor quality data, we know that women can get pregnant after fibroid embolization, but are not guaranteed. And again, when you look at the numbers of the likelihood of live births post fibroid embolization, depending on what study you read, they're all over the map. So how do you counsel patients who, come into you and say, I've heard about this thing about fibroid embolization? What is that discussion you have?
Well, you want me to start, Alexis? Okay. Well, so I'd have to say, just like, all the stuff that we said before, it really depends on the patient. I guess, I think the knee-jerk reaction just from all the, data that you see out there about placentation is to utilize other options before uterine fibroid embolization. Other options such as surgical removal, pretty much surgical removal and surgical removal before something like UFE. But if someone has had multiple fibroid removals and has like a little, what we call the bag of marbles, like they have so innumerable fibroids, we will talk to them about uterine fibroid embolization. It may not be the first choice, but for some patients, it actually may make more sense, even if they're trying to get pregnant. Although I would have to say that, there's plenty of literature out there that says that like it may not be, there may be some increased risks with having a pregnancy after uterine fibroid embolization. But like you were saying, Dr. Wolf, there's more and more data now showing that's more reassuring. So, but I would say it may not be like the very first option I jump to, but it's definitely a tool in the toolkit.
Yeah, and the good news is that kind of goes in line with our society guidelines that got updated, I think, back in 2014, where we said, for patients who have had like no previous surgical interventions, that their fibroids are resectable and they have a reasonable likelihood of pregnancy based on age and all these other factors, that we actually usually counsel our patients that myomectomy, again, is the preferred first choice. But again, like you're talking about, if there's been prior myomectomy, multiple surgeries, they have comorbid conditions for surgery and other things, then at least now we can say, there is studies out there that kind of at least support you can get pregnant. But again, it's a very, very individualized conversation as well. But it's at least not a like hard stop. But, I also think sometimes as things gain momentum, I love what I do, but I also want to get the information out there that, none of us providers should, work in a vacuum or a silo. And so really making sure if you're having a problem with fertility, pregnancy loss, things like that, that you really have these conversations with your, reproductive endocrinologist, your gynecologist, and then also consult a interventional radiologist. That again, we need to work as a team and, not just be like, oh yeah, you can get pregnant after fibroid embolization, so I'm glad that, that's kind of the discussion. But I just kind of wanted to put that information out there because I think there's a lot of confusion and maybe misinformation just around fibroids in general and treatment options. And we still have got a long way to go with the research. And, we had the FEM trial and they did look at the 4-year sub-analysis of pregnancy, but the pregnancy rates were so incredibly low at 4 years in both the myomectomy and the embolization arm that we really can't make any conclusive, comments about fertility. We did notice that at least in the embolization arm, that graph did increase a little bit over time with pregnancy. And we do know that, when we embolize, that it's kind of a global, like I'd like to say we're good and like the particles only go to the fibroids, but we diminish blood flow to the entire uterus. So there may be a little bit, and we don't know, again, this is a hypothesis, maybe a little bit of a stunning that maybe over time after UV that the uterus can recover. So I thought that's kind of an interesting trend we saw from the FEM trial, but again, that wasn't the primary endpoint of that study.
Dr. Wolf, can you do a quick, because there may be folks on the call who do not know what UFE is, what uterine fibroid embolization is?
Yeah, so uterine fibroid embolization is basically a minimally invasive procedure. So I say it's not a surgery because we basically don't make an incision. We make, I always call it like a little nick in the skin, about 2 millimeters. We go into the blood vessels either at the groin, by the hip, or we can even go in through the wrist. And then essentially we just send small little catheters through the blood vessels, and we bind the blood vessels that supply the uterus and the fibroids, called the uterine arteries. And we inject little particles that basically preferentially kind of go to the fibroids, because if you look on an angiogram, fibroids kind of have bigger blood vessels than the normal, what we call muscle or myometrium. And those particles start to plug up those blood vessels and kind of take away the blood supply. So they will kind of shrink and quote unquote, I say die over time. They don't disappear. I usually tell people it's not a magic eraser. So you will always have a scar of the fibroid. The fibroid's not actually being removed or cut out. But on average, they shrink at least 50, probably a little bit more, 60% in volume. And at least symptomatically, we know when we treat women for, heavy menstrual bleeding or what we call bulk symptoms, we're in the, 90% range for both of those of really improving patient symptoms. And that is one thing we learned from the FEM trial that, 2 and 4 years out, when they look at quality of life after myomectomy or fibroid embolization, they both had a significant improvement. Myomectomy may have been slightly improved, but if you look at the data, the quality of life was maybe a little bit lower in the UFE arm. So the overall absolute change is very similar. So that's encouraging. And when they looked at actually heavy bleeding, they were similar. So it's exciting that we do have more tools. And then we didn't even talk about, the ablative techniques, the sonatas, the assesses, the MR guided focus ultrasound, and all of those. Again, it's early, right? But there's at least some promising stuff coming out about fertility. And I believe MR guided focused ultrasound did get an FDA approval for treatment of fibroids in people who want to preserve fertility. So it's really exciting.
It is really exciting, and I think a lot of these technologies are picking up more. So I imagine in the next few years, we will have more and more patients coming in inquiring about this. So I thank you for the information. I think we're all learning a little bit from it.
There was a question about being on the other spectrum, away from fertility. Maybe someone's asking about having a hysterectomy after having a myomectomy, because they had a myomectomy at 29 and wanted a hysterectomy. So, so a hysterectomy can definitely be done after a myomectomy. Sometimes it may be more challenging if there's some scar tissue, but it can be done. So I would just talk to your gynecologist about that and make sure that, that your gynecologist is a good surgeon. Because like I said, sometimes if there's a lot of scar tissue, it can be more of a challenging surgery. So maybe Dr. Wolf should address this next.
Yeah, so a question just came up. Is there any way to know if infertility is a direct cause of a fibroid embolization? If the UFE was the first intervention, no myomectomy previously done, are there any tests or scans that can be done to determine this? So what we know about, again, infertility as a cause of fibroid embolization, you're really talking about the ovarian reserve. So, probably, and I guess our specialists can talk about this, but I think, when we look at, fertility, the anti-Müllerian hormone test, the AMH level, is probably the best test at looking at basically your ovarian reserve. There's been a couple studies out there, I think by Dr. McLucas, kind of looked at AMH levels, both pre and post uterine fibroid embolization. And basically what he found, and this is coming off the top of my head, but if you're under the age of 40, there is essentially, you know, like no increased risk of going into premature menopause or affecting your ovarian reserve. If you're under the age of 40, I believe his data showed somewhere around like the 2% range. And then that did increase from like 1 year post-procedure to like 6 years post-procedure. And then when he looked at women over the age of 45, those numbers did increase, particularly 6 years post. But again, if you look at the average age of menopause in the United States, somewhere around the age 51, 52. So if you're 45 and 6 years out, you're approaching those menopausal years anyways. So we know if you're under the age of 40, and even if you didn't have an AMH level or your hormones tested before UFI, it's really, really unlikely that fibroid embolization caused the infertility from an ovarian reserve. Now, again, if you look at the effects of the placenta, or not the placenta, the endometrium, there have been some studies that looked with the hysteroscope. So they actually went inside and looked at the lining of the uterus. And again, I haven't looked at this data recently, but there was changes in the endometrium, I think within 3 or 6 months post fibroid embolization. So could that potentially affect implantation? That's possible. We also do know from the studies out there, there was a meta-analysis recently done in 2020 that I think looked at about all of the studies out there. And I think there was about 420 some patients with pregnancy post fibroid embolization. And they found that the miscarriage rate was about 27% in that patient population. And they even compared it to myomectomy, and it was statistically significantly higher in both than myomectomy and the ablative technology. So there is some effect. Again, the data isn't great, but those are potential ways that your fertility could be affected post-UFI.
All right, I know we have one more question. We'll try to wrap up. If someone wants to take Kayla's question about myomectomy causing scarring or blockage in the fallopian tubes, and then we'll kind of do a little wrap up.
The short answer is yes, that could possibly happen after a myomectomy. There are lots of things that we can do during a myomectomy to try to ensure that we maintain the open tube that is your actual fallopian tubes, but it is very possible that that could happen. And if your provider suspects that, then they can do some tests to test the fallopian tubes, like a hysterosalpingogram, to confirm that. But I actually have seen this in practice after a myomectomy. Not common, but possible.
So just a couple little wrap-up slides. So I don't know how many people are aware, but in 2022, the White Dress Project did launch a survey on what women know about fibroids. And so this is just some very kind of basic, just number stuff from our study or our survey. Basically, when we looked at the respondents who took the survey, who had a diagnosis of fibroids, then we asked them, you know, what additional diagnoses did you have? And we found that about 7 of those people, so this is the percentages of our respondents who had a diagnosis of fibroids, actually had infertility, which that correlated to about 1.2%. We haven't done any sub-analysis yet of the data to look in those infertility patients. Did they have any of those additional conditions like PCOS, endometriosis, anxiety, or depression? But again, more information to come. We had almost 1,000 respondents in our survey. So we're excited to do a deep dive into some of these other questions. And then what about the obstetrical history in our respondents? And basically, again, these are the people who had a diagnosis of fibroids, and we found that about 7% of our respondents had been pregnant, about 4.5% had living children, about 5.3% would like to get pregnant in the future, just under 7% had never been pregnant, and about 3% had had a miscarriage. So again, a lot more stuff that we can again dive into and slice and dissect the information a little bit more, but we're really grateful for all the women who partake in the survey. And it wasn't just nationally, it was internationally. So we're really excited about that. So next steps. If you're having a difficult time getting pregnant, get evaluated by a reproductive endocrinologist and infertility specialist. I can't say that enough. Continue to educate yourself and educate others, share your story, kind of each one teach one. And, as Tennille mentioned, consider lifestyle options to enhance your fertility.
And if I could add, Rochelle, if you don't feel heard or seen or acknowledged fully by the first doctor that you go to with your concerns, seek out another doctor. There's nothing wrong with getting a second, third, fourth, fifth opinion until you feel satisfied with the answers that you're getting, the treatment that you're receiving, and next steps.
And then the last part of this, so
I'm sorry, I just want to compound that, especially given the guests that we have in the room.
Yes.
And you mentioned this earlier, Rochelle, because I have had personal friends who, when they finally went to see a fertility specialist, it was like the light came on. So keep in mind that if you are struggling with fertility, it makes sense for you to go see someone who has a depth of experience in this and has seen, quite a few different cases, because there are so many of the factors that we've talked about over the course of this talk involved. So again, it is a wonderful idea to see a specialist. And the women in my life that have had, consistent miscarriages and a pattern of other issues with getting pregnant, when they saw a fertility specialist, it made a huge difference in terms of evaluating other options that they didn't know were available to them.
So on that lines, we're super excited to promote next month, What the F, which is basically, can I prevent fibroids? And we have an incredible guest coming and speaking on behalf of his latest research. It's Dr. Al-Hendi from the University of Chicago. And so again, a really, really good segue from kind of what we're talking about today, going into what can we do to help prevent it.
Thank you, everyone. We would be remiss if we did not tell you. So June and July are also packed. June, we will actually be doing a deep dive into UFI. So if UFI is something you're examining, or you know someone who is, please join us, because we will have not only Dr. Rochelle Wolf, but also Dr. Teresa Caridi, who is another very well-known, not only interventional radiologist, but she also partakes in the OBGYN space as well. So we're so pleased to have her, as she sort of sits in both arenas. And then in July, we have our empowerment experience. Everybody put your hands together for our major coming together of women who are wanting information about fibroids, people at risk for fibroids. We actually are going to have a special session on men and fibroids. So how can your partner support you potentially if you're dealing with fibroids and you want a little support, and they need to maybe get a little more information as well. So we hope that you will continue to join us. If we don't have your email, if you got forwarded this from a friend, please put your email in the chat. And thank you, Nicole, for sharing your fantastic story and for allowing us to be graced with both of your presence.
Having us.
Yay! And Dr. Kuo Hung and Dr. Gadsden, can't say enough about having you here and having your expertise. And please continue helping all of the women that you have been helping. And I love that story. You started with Dr. Kuo Hung, with the woman that had all the fibroids removed, and now she's got so we hope that for everyone it works out the way that you would like. But you've got resources. So just know that with the White Dress Project and all of our friends. So thanks, Rochelle and Tennille, and we will see you all hopefully talking about secondary prevention.
So excited. Thank you guys. Thank
Thank
you.
you,
Bye.
everyone. Have a good night, everyone. Thank you so much for taking time out to be with us.
Yeah, thank
Good
you.
night,
Dr. Babson.
everyone.
Thank you, Nicole.
Thank you.